Coming up to the stage, I want to welcome Phil, Mark Edwards, the Assistant Director of Division of Social Services at Dallas County Health and Human Services, Janice Sparks, PhD, and the ED of Catch, and then Christina Bartha, CEO of Texas Healthy at Home. Come on up.
Thanks, Ed. Thank you. Appreciate that, Eric, that introduction. So this session, we're going to talk about something that is a trend we're seeing in the healthcare marketplace, and want to see how we incorporate that into non-medical drivers of health in the community, especially here in Dallas as well, in particular in Texas. So it's called Profit with Purpose, is this particular session. But what we're seeing is, I should say what I'm seeing is there's a lot of value-based arrangements that are being done between health plans, health systems, and other service providers when it comes to clinical care. And that's the trend we're seeing, is if you can accomplish X, if you can accomplish this quality, and let's all remind ourselves value-based care is theoretically defined as higher quality at lower cost. And so they're paying for the quality that they derive. Obviously, in a lot of the capitated agreements, even with managed Medicaid and Medicare Advantage with health plans, that in definition is value-based care because they pay them a single payment to take care of members. And so it's at their responsibility to do it in an efficient way or a productive way. But an example that was thought of earlier was, we will pay for a lot of a visit to make sure a diabetic stays within the range of where they need to be with their chronic illness. But then no one thinks about, well, what about the individual who goes to the house and finds out there's not a refrigerator to keep the insulin cold, right? What happens then? Because that has a detrimental effect to that chronic illness. But yet that portion is not necessarily at this point in time being included in those arrangements. So today, as was announced by Eric, and I'm going to I think it's important that everybody introduce themselves. But we have Christina Bartha, who's the CEO of Texas Healthy at Home, Mark Edwards, Assistant Director of the Division of Social Services, in the Dallas County Health and Human Services Department, and then Janice Sparks with the Community Care Hub of Catch in Houston. And so Christina, let's start with you, and why don't you introduce yourself quickly so when we start asking you questions, everybody knows who you are. And then we'll go on to Mark and then Janice.
Okay, perfect. Hi, everyone. As Phil said, I'm Christina Bartha, CEO of Texas Healthy at Home. It's a pleasure to be here. Thank you so much to Blooming Health for putting this together. Texas Healthy at Home is a 501c3 nonprofit organization. We were founded in 2016, and we provide strategic vision and leadership in expanding community-based health and human services and improving care outcomes for Texans. We have a network of dozens of partner organizations, including across sectors from academia to healthcare organizations, area agencies on aging, and community-based organizations. And we work with our partners to maximize cost efficiencies, generate new revenue streams. Texas Healthy at Home provides kind of administrative backbone support as a community care hub for our partner organizations so that they can do the work that they do well in their local communities, and then we can go out and we can support them on the administrative side of things. We also co-lead a couple of statewide coalitions, including the Texas Takes on Falls Coalition, focused on falls prevention and reducing fall risk, and the Texas Elder Justice Coalition, which is focused on combating financial exploitation of older adults. It's a pleasure to be here. Thank you.
Thank you. Mark.
Good afternoon, everyone. My name is Mark Edwards. I'm the Assistant Director for Dallas County Health and Human Services, Division of Social Services. As you might know, Dallas County Health and Human Services has a plethora of resources ranging from vaccinations, immunizations, sexual clinics, and that's the public health side. I have the privilege of overseeing the human service side, which involves a number of social care services, everything from utility assistance to our weatherization assistance program. We have a welfare program for folks that might be impacted by a disability or a pregnancy and have a loss of income. We have a home loan counseling center for financial literacy and education and for first-time home buyers and throughout the Dallas County area. And one of our best kept secrets is we have 19 senior centers throughout Dallas County. And it's kind of a hybrid model where we don't bring seniors to the center, but we go to where the seniors are. And so that's an awesome opportunity. And then we have a social service resource center where we are doing all the benefit enrollments for clients. And one of the things that we focus on is an internal partnership as well as external.
And I'm Janice Sparks. I'm the executive director of Catch Community Care Hub. And we are a collaborative organization that brings together Houston Health Department, Ibn Sina Foundation, Houston Health Foundation, and UT School of Public Health. And so much as like Christina was saying, as a community care hub, we stand in the middle of healthcare organizations and community-based organizations to help facilitate integrated care between those two entities. I'm happy to be here and thank you for having us.
Thank you. And thank you again to all three for being here with us today. So we're going to touch on this subject. I'm going to start with Mark and say, I know Mark's, tasked with one of the things he is tasked with is connecting vulnerable populations to a massive safety net in one of the largest counties here in the state of Texas, or in the country for that matter. So when we talk about profit with purpose, how does a public health department define a return on investment? And is it strictly about cost savings, or is there a broader non-medical ROI that we should be measuring as well?
Thank you for that. That's an excellent question. When we talk about profit with purpose, it means different things to different people. But I think for everyone in this room and those that are listening online, it's more than a financial profit. We have to move from financial profit to community gain. And what does that mean? That means bringing community partners together. That means appreciating the frontline staff, the caseworkers, the case managers, social workers that are all on the front lines doing the hard work, partnering with healthcare providers, healthcare systems, and community-based organizations, which are also critical because they've got the boots on the ground and they know it better than anyone else. And so when I think of profit with purpose and the ROI on that, I think of peas, the vegetable, the first letter being P for prevention. And as I see my manager for our weatherization program is here, Daniel, he goes into communities and there are families that are impacted during the extreme heat because they have no working air, or the dangerous cold because they have no working heat. And those are preventive measures that also impact our healthcare system. The next letter I think of is equity. See that little image of the three boys trying to look over the fence. Everyone can, because all the boxes are the same size. And if we're going to be successful in this area of social care, we've got to increase the boxes for certain communities so that everyone can see over the fence. The next letter is access, A for access. We've got to create opportunities for access. Many of our underserved communities are lacking access of transportation. They live in food deserts, so they don't have quality meals. And technology is a big challenge. We've been talking about AI. Our communities, our underserved communities don't have access to that type of a form of technology. And all of that for the last letter creates stability life. And that's what our goal is.
Thank you. What I took from that, what was interesting is, a lot of times people will say, oh, we just don't know the return on investment for doing these non-medical drivers of health. I think the real issue is there's return, but the return's in so many different places. The community has return. The health plan has a level of return. The health system may have a level of return. And so, whereas in a lot of circumstances, you're only trying to define the return in one place for one beneficiary. But in this particular work we're doing, there are many beneficiaries of what, in addition to the actual individual, but beneficiaries, financial beneficiaries to what we do. Thanks, Mark. So I'm going to go to Janice with Catch and say, Janice, your work in the Houston and Harris County focuses on that critical closing of the loop during transition care. We know that a patient's zip code often predicts their readmission risk more than their lab results do. What are the specific community-based support pillars that Catch has found to be the most effective at preventing that 30-day bounce back to the hospital?
So one of the partnerships that we have in the Houston area, and we're working with Houston Health Department with a hospital system, is we use a care transitions intervention that has 4 pillars and it's evidence-based. And we found that utilizing those 4 pillars is a way to reduce readmissions and the bounce back. It's not just the intervention itself, but it's also the individuals who are working with patients to prevent readmissions. So in that intervention, we're using community health workers. They connect with the patient, go into the home, they do a home assessment, they ask many, many questions, but the heart of asking all those questions is to prevent the readmission. And so we found that with every hospital system that we've worked with, we've been able to not only reduce readmissions, but also address those non-medical drivers of health that are impacting the reasons why they go back to the hospital. So we've just found that selecting a great intervention has been beneficial, but also I think no intervention is good without good people who are implementing the intervention and working with individuals and patients in their home and walking with them and beside them. And in talking about technology, and I know someone else said this before, technology is great, but again, technology is not as good as it could be without the people who help maximize what it is.
Thank you. No, that's great. Yeah, technology can't go into the home, can it? And look around, at least not yet. I don't know if that's going to happen sooner or later, but it can't do that. And I guess I'm going to harp on the same topic because you're in the home trying to prevent a readmission, but in so doing, that individual is looking and seeing so many things and probably helping so many things that add value to different parties, even looking at fall risk for a senior, for an aging population. Does that help stop the readmission? Possibly, but it helps the longer term issue, which is generally the MA plan or traditional Medicare that's going to receive the benefit of somebody addressing fall risk. So the magic is going to be the day that we can figure out how to get everybody to pay for those activities that are being done on a transactional basis versus a general funding basis. All right, Christina. So as the CEO, you provide strategic vision for expanding community-based services across Texas. But for healthcare leaders who are still skeptical of the value-based care model, what is the strongest business case you can make for investing in home-based social services before a health crisis occurs?
Well, I really, just in preparing for this panel, it really just seems so simple. And I'm like, what am I missing? What am I missing? But I really feel like it comes down to this. Stability at home is far less expensive than crisis in a hospital. So under the value-based care, healthcare organizations are accountable for total cost of care and long-term outcomes. That means a preventable hospitalization isn't just unfortunate, it impacts financial performance. So a single avoidable admission can cost tens of thousands of dollars, whereas home-based, community-based services like transportation, assistance with medication adherence, food access, caregiver support costs a fraction of that. So at Texas Healthy at Home, we and our network of partners across Texas are known and trusted in our local communities. And that trust does matter. It matters a lot, but it's not everything. We need more than that. So Texas Healthy at Home and organizations like ours and community-based organizations are cost management partners inside of value-based systems. It's just it's a shift in thinking, but we actually can help with the costs and be part of the solution.
That's great. I think, well, I agree with the comment. A lot less expensive to fix what's happening at home before someone ends up in a crisis. And I think part of the problem that we have in our country with non-medical drivers of health is our whole healthcare system is based on an episodic payment system. And it's hard for people who are used to doing that. And I guess I'm going to say a health plan in general or Medicare or a Medicaid plan is used to paying for the episode, to say that one visit to that home had this value and therefore I'll pay for it. I'll pay for that. And that's part of our issue is we need to be looking at longitudinally at care and longitudinal payment models versus simply transactional models. I'm not saying I know how to do that, by the way. I think that's one of the things we need to focus on in this country. And I know there's a lot of health plans and a lot of health systems who will invest in the community in the sense of a grant. And I don't mean to be cynical, but I guess it's going to come across cynical that when you see a grant of $400,000 into the community, I've done the math, and so you can believe me or not believe me, but that's like me taking a $20 bill and giving it to somebody. So the focus isn't there in a significant way to say this is making a difference. And so I think the onus is on a lot of companies, and I can include Blooming Health in that, to really derive or extrapolate the value of this activity into the long-term cost of care of these individuals. And we need to be more prevalent in doing that. So Christina, I'm going to bug you again, I guess. It says integrating non-medical drivers of health into financial models sounds great on paper, but it's hard to execute. What is the biggest operational hurdle to getting high quality, efficient home care delivered? And how do you ensure the compassion doesn't get lost in the efficiency?
So we've been talking about this for a long time, and I'm still going to say the biggest operational hurdle is fragmentation. And I noticed that Blooming Health on the about, when y'all are talking about what, the reason for the founding of Blooming Health, fragmentation was something that was a piece of that and a reason for it. So community-based organizations, healthcare systems, and social service agencies were built separately. And, they were built with different funding streams, different eligibility rules, different data systems. One thing I see frequently is just we speak different languages. So, when you have different sectors in the room, it's great, but trying to understand what each other is saying and how each other is working is a hurdle in itself. So we all come from different spaces, but the person, the individual, the human that we're trying to serve isn't experiencing that way. They're experiencing, just their experience and whether they're getting the care that they need or not. So I would say on the question of efficiency and compassion, in my experience, those go hand in hand. They rise and fall together. So when systems are unclear, staff spend their time navigating confusion instead of helping people. But when processes are defined and expectations are aligned, they have more capacity to focus on the individual. So the structure that we're building at the hub level, like for Texas Healthy at Home, is a community care hub that has this network of partners across the state. that structure is allowing our partners to deliver care in a way that is not only structured and organized, but also compassionate.
Thank you. You know, it's really interesting that compassion versus efficiency, that you made the statement, they rise and fall together, because a lot of people think naturally that they're opposites. The more compassion, the less efficient it becomes, and the more efficient, the less compassion. I think a lot of people would be interested to know that even in our models with Blooming Health, I talked about the micro agents or the small agents. There's a compassion agent that you can turn up the volume or turn down the volume on how much compassion. I know people think an AI agent can't show compassion. It can be trained to say the words that make you feel like they're compassionate, even though they may not be compassionate in and of themselves. But that's one of the fears I have of community health workers being involved in episodic care and payment is as soon as that happens, which I think it will happen, it has happened in certain states in Medicaid plans where community-based organizations can bill manage Medicaid plans for the activities they do. Do they now get stuck into the efficiency model of we've got to do it quicker, we got to do it faster because that's how we make more margin on what we do? And I know that's not how you think right now. And so part of me doesn't want you to think that way, because then that takes a little bit of the purpose out of it. All right, this is whiz questions for both Mark and Janice. So we'll hear from both of you, but both of you work at the intersection of clinical care and non-medical support. How can large public entities like Dallas County, HHS, and specialized nonprofits like Catch better share data to ensure a patient doesn't fall through the cracks during a transition from the hospital to the community?
Okay, so we believe in developing really strong integrated data systems. And so we, I think it was mentioned earlier, we have access to our HIE, but also since one of our core partners is the Houston Health Department, we also have access to their data and can tap into all kinds of data that is city specific as well as county specific. So we just believe that data will enable us to better understand our communities and better understand the people that we're serving. And so what we're planning to do as we're building the infrastructure for our data system is to give access to our community-based partners who are going to be doing the work. And sometimes there's this rub of, okay, well, if you're building a community care hub, will the CBO partner pay some fee, or how will they have access? And we are saying no, part of being a partner with us is having access to the data. Of course, we're going to have data use agreements and things like that in place. But once those things are taken care of, we want it the data to flow naturally between our organizations. And so, you know, if the information is not collected, if data is not being utilized in a way that's going to benefit the patients or the people we serve, then, you know, what's the point of collecting it? We want to leverage that information that we have about individuals to help better serve them. So data is really key in the infrastructure that we have with Catch.
No, I echo everything Dr. Sparks just said, in particular as it pertains to shared data between organizations, healthcare providers, and even government municipalities. So we're in that same space trying to create that. But right now, just from an internal standpoint, the county's fairly big, and we've been dedicated to trying to get different departments from working out of isolation and working in more collaboration. And a big part of that is data sharing. In other words, we'll have individuals go to our sexual health clinic and no one is addressing their social needs, social care needs. And so if we're able to create a data system where we can integrate that information and send it upward to our resource hub, then they can reach out to those clients and be able to provide a holistic approach to services. And so we're really dedicated to that, where we're sharing all of our valuable resources with a hub to identify those needs. You may have somebody that comes through and they're in need of SNAP benefits and they don't know how to go about it. We should be that agency to reach out and provide those services. So that's how we're kind of incorporating shared data.
That's great. I think that's part of the promise, specifically for community care hubs, is that that's what that's supposed to be, right? A shared entity. Because I keep on thinking, if a referral comes into a community care hub from a primary care physician and it gets resolved, that data becomes invaluable to now a hospital system where that person may appear later on to understand that that was happening, to be able to dive down and see if that's still the need that is causing some of the issues they have. So I'm happy to hear that that sharing is, the intent is there, and that's what's supposed to be happening. All right, Janice, I'm going to pick on you again. This is a similar question that was asked to Christina earlier about closing the loop. You see a lot of different non-medical needs that come through. And we're kind of focused a lot on hospital readmissions, but it could be just about anything else. But well, I guess we'll be specific to hospital readmission. What is or do you see a prevalent need that, if solved, stops hospital readmissions from happening? Kind of like the number one that you'd say out of all the needs that are there.
So it's really interesting with this iteration of the care transitions program that we have. Usually it's like the top three: housing, transportation, and food, insecurity that people are struggling with. But this time around, it happens to be transportation and continence supplies, and people needing what we call benefits counseling, or not understanding like their health plan, not knowing how to navigate different systems. And so it seems as if I think we all need to be open to, okay, yes, statistically, maybe there's a lot of data that says that the top three: transportation, housing, and nutrition and security, are the things that you need to focus on. But I think with any intervention, we have to be open to being flexible with tracking what the needs are, but also having resources in place to support addressing the unexpected things that we thought that wouldn't appear. And so having that infrastructure to be able to close the loop and address those unmet needs, or needs that we never thought were even on the radar, like really seriously, incontinence supplies of all things. But that is something that right now people are really struggling with for whatever reason. And one of the things that we think about is like, well, how can we address this? Where are we going to get how's it going to be addressed, and how can we minimize that need and reduce maybe the need for it, if that's even possible? But at least it gives us, collecting that data and seeing what's going on, gives us kind of a lens to see what's really happening and how we can best address the issues and close the referral loop.
That's really interesting, because I think that question could be asked of many people in different areas of the country, and it'd probably be a different answer depending on where people are. I had the opportunity to I worked with Kaiser in Southern California around not readmissions, but preventing avoidable ED visits. And what we ended up doing was a real big health literacy campaign around urinary tract infections, because that was the number one avoidable. They had tons of people coming into the ER for UTIs. And it's because there are probably other needs that drive that as well, but they just let it go so long that all of a sudden the only thing they can do is get to the hospital as soon as possible. So it was a lot of education is what you can do. All right. I just got is that till the Q&A, or is that including the Q&A? Till the Q&A. All right. I'll ask one more question of Christina, and then we will do one question for the whole group. Christina, Texas Healthy at Home is scaling its services across the state. It's as geographically and economically diverse as Texas. How do you standardize your value-based models while still remaining flexible enough to meet the unique needs of a resident in a rural pocket versus someone in an urban center?
Yeah, this is a very good question, and it's tough. I mean, Texas is huge, as you all know, and diverse. So as we scale across Texas, we've had to be clear about what gets standardized and what doesn't. So what stays consistent are the outcomes that we're accountable for. And the way that we achieve those outcomes may be different depending on where we are serving in the population that we're serving in the geographical area that we're serving. So some of our focus areas, reducing avoidable hospital use, improving medication adherence, helping people remain safe and independent at home. Those goals don't change based on geography. Whether someone lives in El Paso, Lubbock, Dallas, or a small rural county, the healthcare system is measured on cost and outcomes. So, like if you take some rural areas, transportation may be the primary barrier. And if someone can't get to a follow-up appointment or the pharmacy, everything else falls apart. In parts of our larger urban centers, we may see more housing instability or caregiver burden or social isolation. The underlying financial logic is the same, but the intervention mix has to be tailored to the specific areas. So as a community care hub, you know, we as I've mentioned, we have a network of partners across the state who know their local areas and the needs and the intervention mix that's going to work for the people in their communities. So we rely on our partners to identify, you know, the intervention mix that's going to work the best.
Wonderful. Appreciate that. It's a lot. It leads into the last question that I'll have every one of you respond to in the last 5 minutes that we have. But it says, if we move successfully to a profit for purpose model, what do we think, looking into the future, what do we think the hospital discharge process should look like in 2030 or beyond? And it should, I mean, I think I know the answer to this. You know, should the non-medical be as common as the medical outcomes of that discharge process? Let's start with Mark and we'll come back down this way.
Great question. And I think, again, it boils down to why we're all here today, because we understand that non-medical drivers actually determine one's medical health. And it's critical for us to increase the cost and the value around non-medical drivers in order to decrease the cost in healthcare systems. And so when we're able to pull communities together, gather resources and go into communities, because a lot of our underserved communities can't get to healthcare systems. We have to go to them. And one of the things that I'm excited about, I see some of the Dallas County Social Care Coalition members that are here today. Our model is actually to go into underserved communities and bring those resources to community, and that's where your ROI is for social services.
I would say that I think there needs to be an equal playing field or a level playing field between non-medical and medical, because historically, and this is has been my experience, we'll have conversations with medical communities or organizations, and there's a kind of a power dynamic that is not level or equal. And so social or non-medical care is seen as less important in my experience. But I think we're moving in a direction that's really exciting, to where we're having better conversations between healthcare organizations, to where they see the value of non-medical factors, and they see how non-medical factors are, in fact, more and more, they always have been, but they're actually like acknowledging that non-medical factors are impacting health outcomes. And so I would love to see the day where we come together with healthcare organizations. There's an equal conversation between our organizations, and then really, truly, non-medical community-based organizations will get paid what they deserve, because that hasn't happened. And we needed to keep our doors open just as much as medical communities do. So that's what I would love to see.
This is a really cool thought experiment. I hope that all of you are thinking about the question for what would be the vision in 2030 if we move successfully toward a with purpose model. What does the hospital discharge process look like in 2030? That can be really exciting to think about. I mean, and to really believe that it could happen. So for me, in 2030, discharge planning would begin on admission. So discharge wouldn't mean good luck. And if you've had a loved one in the hospital, most of us have, right? And the discharge process, it's hurried, it's rushed, it's confusing. You're under a lot of stress. Your loved one who's sick is under a lot of stress. So the discharge process would be, confirmed transportation, confirmed medication access, confirmed food security. So and social risk screening would be as routine as taking the vitals. So it's equal measure. I mean, you're dealing with the medical side of things, but you're also dealing with the social or the community-based, what they're going to face when they go home and walk through the door to whatever home environment they're living in. It's really, really important to be from start to finish, keeping that discharge process in mind and what it's going to look like for that human patient when they go back home.
I think those are all great responses. If I were to give my response, it was going to be in a real short. It's all hands on deck, right? It's when somebody gets released from the hospital, and I love what Christina just said, because it's like all the due diligence was done during the visit, and the discharge now means we've already notified the various community organizations that need to be involved in helping solve the problems, even if it's a ride home from the hospital, and making sure that they feel almost like VIP treatment when leaving the hospital, because a team of people are helping them. And then obviously, Blooming Health needs to sit in the middle of that too, right? No, kidding, but we'd love to be the one to outreach and to be following up with them to make sure all these plans are actually happening and that they're satisfying the needs of the individual. Because that's what we try to do, is discover the needs and help utilize community-based resources to solve those needs. And that'd be a wonderful day. And then it has to be funded, right? All that team needs to be funded. But I think if we were to bring people all together, health plans, health systems, and everybody else, there could be a joint funding of all that activity, because they are the beneficiaries of all that happening, to prevent those readmissions, to make sure that person stays healthy. Because it's not just what immediate needs they have, is how do you feel on day 2 when you leave the hospital? That's a big deal too, because here we are trying to be in the face of people who leave not feeling great, right? And so we need to figure out if there's things that need to be done, even clinically or medically, to help them when they're not feeling great on day 2, and educate them on what they do about those types of things as well. So thank you to the panel. I think we're going to open up for some question and answer right now.
I have one question that I'm sort of pressing to ask, and I want to go back. I guess Christina's, Mark, you may not have been here this morning when Commissioner Daniels spoke on the fact that we do nothing by ourselves. And I want to take Phil's $20 grant that he received, and I want to ask in terms of what can be done, or how can we entice players in the county, the state, to sort of share resources, to work together more in terms of making sure that we serve everyone. There was a gentleman at this table that came over and offered resources to us this morning, and that was sort of reassuring, because we don't have to just share money, we can also share information about resources. So my question is basically, and I'd like for all of you to answer, if you can think of how we can encourage players in our state to share opportunities and resources.
Let me just maybe give an example. I just want to give a quick example on how we are trying to, how Dallas County Health and Human Services is trying to meet that need and close that gap. One of our specialty programs, our disability program, which provides financial assistance for anyone who has a loss of income or pregnancy due to a disability. And so what we have done deliberately is worked with our healthcare providers, our social workers, case managers at Parkland Hospital, at Baylor, at Methodist, and the like, so that they have that information of resources that they can refer their clients when they're being discharged to Dallas County so that they do have available resources. So we wanted to continue to build upon that collaboration with healthcare systems within Dallas County.
I'm going to say something that's kind of out of the box. First, Jessica, what you were saying about the gentleman who came and shared a resource with you, I think one of the things is just getting in a room together, like having regular meetings and talking about the problems and issues that our communities face. I know the United Way of Greater Houston has a couple of monthly meetings that where community-based organizations come together, and part of one of those sessions, those meetings, is problem solving. In the last this month, there was a really good session, and it was probably one of the longest ones of just people stood up and said, I have this problem. Somebody said, I have an answer. And it was not even necessarily financial. It was just what happened here. It was just that they shared information. But I also think that we're going to have to diversify the way we think about generating revenue and generating ways to fund the programs that we want to provide, because I think that there are opportunities for all sectors to really work together. But I think one of those, at least from my vantage point, is I don't think that we tap into different for-profit entities like I think that we could, or technology companies like I think we could. And I think going back to data is so powerful. And if we start collecting data and sharing what we know related to, hey, I know what's going on at your health plan because these people are calling us and they're saying they have these problems, we can leverage data and leverage information in a way that can help generate conversations that can hopefully encourage people to fund different opportunities. So especially in light of the way funding has been cut, I just think we need to have out of the box thinking to try to come up with solutions to fund what we need to do to help communities.
I agree. I agree. So the collaborative gatherings, convenings like this, like what Blooming Health has done today, I think that is incredibly effective. While, virtual meetings and all of that, and Zoom and Teams and that we're all on so much these days, they serve a purpose, and we have to do that sometimes. But I think it's important to be together in person discussing these issues with each other and understanding each other's positions and each other's realities, and understanding each other's, the sectors that we're working within. So having a spirit of collaboration is really key to get these big problems solved together.
Thank you. I'm going to add one little bit from my standpoint. I think it's already mentioned, that's what Blooming Health is, what we're trying to accomplish by getting people in a room. But the next steps out of this room, and this is my experience over 30 years in healthcare, we tried to make this a Blooming Health Texas Day. It's not going to happen at a Texas level. It's going to happen at a community level where the health plans who have members in those communities, a large hospital system in that area, the community-based organizations get together and they figure out how to make that work, a sustainable revenue model for an area. And I think that's how, that's how I think it starts, because then that will, when successful, which I know it would be, we'd love to facilitate that and then bring those communities, bring those entities together. We're trying to do it. We do it at a state level. We couldn't afford to do it at a county level in Texas. That'd be very expensive to do it for every county. But that's where it needs to start to happen, is at those levels. And then when successful, it starts to gain traction and creates momentum across the entire state and then hopefully across regions and then the whole country. But that's how I think. That's my personal opinion.
Good afternoon, everyone. I have a twofold question, and I think it's to piggyback on the question that you've already asked. I guess maybe if we can delve deeper. Some of you guys have already provided some of the feedback that I was looking for, but I'm an individual who manages client-facing programs. So the the ADRC, which provides information and resources for individuals who are disabled or 60 and over, but we also participate in the LCA program, which is a money volatile person that helps individuals who are transitioning from skilled nursing facilities back into the community who don't have Medicaid. I also work with the call center. Individuals call in, but we also manage other IDD programs as well. And for someone who is not a Texas native, coming from another state, it's been really shocking to see how fragmented and siloed the social service agencies are and the different systems that work that are, that should be integrated. So I know people say I have to adjust, but that's really not something that I want to adjust to because I think it can be done differently. So I would like to ask, how can we do better, or I guess find better ways to collaborate across systems? That's my first part of the question. And then the second part of the question, oftentimes I hear where it's never been done like that, or that's just not how things work. So could you guys provide feedback on how we can challenge those systems and really try to mitigate that mindset of this is just how things have always been done?
I'll go first. Hi, Fallon. Thank you for that question. I think I don't know about you all here, but I have been to enough collaborations and coalitions where nothing is being done. All it is a conversation. And so we do have to sometimes look at the infrastructure versus the accountability and the responsibility as agencies to put our resources in the right place. In that regard, I mentioned that we have created formed a Dallas County Social Care Coalition that is designed to go into communities so that it's action driven and not just a conversation left at the table. And we want to continue to build that. I see Dr. Kitzman's here. And what I'm finding is that I need to figure out how I can bring coalitions together because there's strength in numbers, and bringing more resources to those underserved communities where individuals don't ever leave those communities, regardless of their health condition, regardless of diabetes, hypertension, whatever chronic illness, they will stay right there because they don't have the resources. We need to be committed and accountable to bringing resources to underserved communities.
Okay, I'll go. So when you were talking, one thing that came to mind, I have a mentor and we would go to meetings and be concerned about something. And it would run the gamut from people who worked at the state, local level, things like that. And we would leave the meeting still, and not to, I don't want to seem like I'm picking on the state at all. I'm just saying it was a group, it was, a host of different organizations represented. So you think, okay, it's people who with influence and the ability to make change and do all of these things. And we're so passionate about what we're wanting to change and what we see. And one thing of encouragement, because she's been in the game for a long time, and she just said, Janice, just stay on message. If you have something that you are trying to achieve, stay on message. So they may have heard it 10 times, say it 10 more times. And interestingly, with that issue that we were concerned about, we brought data to the table. We kept the conversations going and things changed. And so I was talking to Dr. Kitzman earlier today about how we're part of this big continuum. And even though it may not seem like we're doing much of anything, I think every time we get together and every time we talk about something, we're making a difference, even though it doesn't seem like it. So I just say for all of us, just stay on message and let's keep fighting, keep going, because we will make a difference.
Great question. Texas Healthy at Home, as I mentioned in the introduction, we co-lead 2 statewide coalitions. Texas Takes on Falls Coalition and then the Texas Elder Justice Coalition. And coalition work, to your point, Mark, I mean, it's tough because especially when so I've been a part of let's take the Texas Takes on Falls Coalition. I've been a part of it since like 2009, or I mean, a long time, and it's been in existence for a very long time. And now as we're co-leading it, we're thinking, okay, well, we really want to do something, make some sort of a meaningful change. So, one thing, coalition work, coalition of the willing. And I got this advice from a mentor early on. If somebody's not into it or they're not passionate about it or they want to let them go. You are going to have a core group of people who are ready to go and take action, because we can't sitting around the table and talk. It's great to be in person and this is wonderful, but the action after these events or the meetings or whatever is what's really important. And there are people who are going to stand with you and move forward in action. One of my team members, I have to call her out, Jamie is here, Jamie Taylor, and she's all about action. She's like, I am not going to show up if there's not going to be any action items afterwards and noticeable change. So don't, take heart. It will happen. Just keep going. To Janice's point, it's important just to keep moving forward little by little. And it doesn't happen fast. That's the other thing. It doesn't happen fast, but it does happen over time. Having a plan too. We just developed a strategic plan for the Texas Takes on Falls Coalition. That's super important. Along with that strategic plan, we have a work plan of detailed action items on how we're going to do what we say we're going to do. And then accountability. We're all holding each other accountable for it.
Yeah, I just wanted to tell you about, we have something called the North Texas Community Health Coalition that was started through the Clinical Translational Science Award at UT Southwestern. I'm at Parkland now, but it's a body that is now 65 community-based organizations, so big ones, small ones, the YMCA, Veterans Consortium, Mexican Consulate. We meet quarterly. We provide lunch. We do all the logistics. We kind of move around from different organizations that are willing to host us. And then we also have a listserv that we manage, a website that has everybody's contact information. And really, we also have things on there for grant applications, like text that you can put in your grant to say I'm part of this coalition and we'll be able to work together if we get these funds, blah, blah, blah. And that's just sitting there that you can use at any time. Letters of support from me. So we're really trying to do this in the North Texas area, really Dallas, but surrounding, Arlington, not yet really Tarrant County, but Garland, Irving, Plano, of course, the southern sector, but there's poor people in need all over Dallas. So we really try to expand out. And one of the things about coalitions is it's important that the members are getting something out of it. So we've tried to create a structure where if you're a part of our coalition, we will give you free grant writing help. I can't help you every day, but I will help you. We give you letters of support. We send out information on grant opportunities, webinars. We try to cross-pollinate across these 65 organizations. But the big thing we do is we provide free health screenings to anyone who's a part of our coalition within our budgetary allotments, which is usually 2 to 3 a year, sometimes more. We do it for DHHS and the YMCA. And that providing something to their clients, in addition to them, has made them want to stay with us and invest with us. So yeah, we're here. So come join us. North Texas Community Health Coalition. I'll give you my info.
All right. Well, thank you, everybody. And again, I'd like to thank our panelists for coming and and sharing their expertise with everybody. So I'd love them to get a round of applause for these three. Thank you. Now there's a break. I'm going to give it back to Eric, who's going to tell us what's going on.
Thank you very much, Phil.